What we do know is that HIPEC, or heated intraperitoneal chemotherapy, has been recently shown in a randomized trial to be effective in a few particular instances. So before we get into that data, let me explain how we think it works. So we've known since a study called GOG 172, where we gave women with advanced ovary cancer chemotherapy through an IV or chemotherapy directly into their abdominal cavity, that outcomes, progression-free and overall survival in the group that got intraperitoneal chemotherapy benefited. There was a significant progression-free and overall survival advantage in that group. The adoption of intraperitoneal chemotherapy across the country to treat women with ovary cancer was somewhat stymied by a number of things. It's difficult to give, and there was concerns about morbidity, it required hospitalization. So those of us that give this chemotherapy recognize that it's much more difficult than an IV infusion, despite the benefit. And that therapy required multiple admissions to the hospital. So we've modified the regimen, but recent studies have not necessarily shown the same effectiveness at the same time as we started giving Taxol, which is one of the key drugs in ovary cancer, weekly. So cut back to where we are now. Some of us started giving HIPEC to women with ovary cancer with the thought that, well, if we're giving drug into the abdomen, there's a lot of reasons theoretically that this would work better. First, during surgery where we debulk disease down to minimal, or in this case we aim for no gross residual disease, by administering chemotherapy right then and there, you'd think that would be the most effective because we have the fewest cancer cells to treat. So in the operating room rather than 3 weeks after recovery from surgery. In addition, when we give it in the operating room, we know that heat is actually cytotoxic for cancer cells, and so there's, at least in experimental animal models, there is a synergistic effect of chemotherapy and heat. One of the things we postulate about intraperitoneal chemotherapy at normal temperatures, like we have been giving on 172, is that tissue penetration of this drug is higher than when we give it IV, and heat increases that, so we get deeper penetration. And finally, when you're doing a surgery, you've debulked all this cancer, there are no adhesions or scar tissue that's formed yet because you're still in the operating room. So there's a third advantage. There's not going to be any compartment that's not going to see this drug. So centers like here at the Cleveland Clinic and in other places around the country and the world have actually been starting to offer HIPEC in certain select cases. Most of them have been done in patients with recurrent disease. However, there's new exciting data out that was just published in the England Journal showing a benefit in the upfront setting. So the New England Journal of Medicine published a randomized trial looking at women who have ovary cancer. They were all advanced staged, and they were randomly assigned after neoadjuvant chemotherapy to go to the operating room, which is standard care, and then half of them received HIPEC with their surgical debulking, the other half didn't. And lo and behold, there was a statistically significant advantage to the folks that received HIPEC in both progression-free and overall survival, with really no increased morbidity, which is really where a lot of people have problems with this. They think, oh, there's going to be lots of complications, bowel leaks, and that was not borne out to be the case. So in some people's minds, this is practice changing. People that, get neoadjuvant chemotherapy, it depends on what side of the fence you are, and some people think they don't do as well as if they get surgery up front, but there's been a study showing they do. Regardless of where you fall, clearly the data suggests that HIPEC is beneficial at the time of that interval cytoreduction. So that's the data in the New England Journal. There's also data that was presented at ASCO that show that women with recurrent disease undergo debulking. They were randomly assigned at that point to have HIPEC or not. And again, that group had not only progression-free, but overall survival advantage. So I think this is very exciting data. This is the first time, honestly, since GOG 172, the intraperitoneal chemo, that we actually move the needle in both progression-free and overall survival. And I know the critics out there are saying, well, that's not true. It is. If you look at any study, we move the needle with progression-free survival, but we don't generally move how long people live or overall survival. So if you look at the new data that's come out with PARP inhibitors and things like that, we haven't shown overall survival advantage yet. Maybe we will. But I'm thinking that this is pretty clear.